fortunate to have, thank you, Dr. Gina Kang, who is here today to speak to us about palliative care considerations in diverse populations. And we just invite all of you to enter your name and name of anybody who's with you into the chat and where you're from. And when you're speaking, please unmute yourself and introduce yourself. And if you can, we'd love to see your faces. We, as social beings, really connect with seeing each other's faces and hearing one another's voices, although we understand, of course, if you can't. We take this very seriously. We protect PHI with, respecting confidentiality and in following HIPAA guidelines. So don't forget also that all of our sessions are recorded and they can be viewed again on our website. And then please do complete the 1-minute post-session survey so that we can have continuous improvement. And we want to hear your feedback so we can get better and address your concerns. Upcoming in December on the 9th, for November and December, we have one session in light of the holidays these months. And so we'll look forward to see Dr. Angela Hansen, who's going to talk to us about diet, a solution-focused exploration about how to help people transition to add in healthier options. And then here's a sort of a sneak preview of what's coming in 2023. And this is not in any order yet because we are confirming people's availability, but just to review this list, I'm not going to read all of them, but we're very fortunate to have Dr. Brock Gastor talk about his work on cognition and aging as an example. And then there is an upcoming conference in March that we are providing through Swedish, which is really a broad neurology update for primary care. So during this conference, you'll hear talks on dementia, of course, and also headache or movement disorders, neuromuscular disorders, epilepsy. And so we're going to pop the link in the chat and you can take a look. And then again, call to action. Please bring your cases forward. Any case really is an opportunity for us to learn together, and in particular, the person bringing the case together. So reach out, with us. So reach out and talk to Allison or email her. And we need cases. So please bring your cases forward. We have CME and CNE accreditation for our University of Washington Project Echo Dementia. No financial disclosures, and should we ever have any disclosures, all relevant financial relationships are mitigated. Okay, so this is our hub team, and we have provided almost, close to almost 800 hours of instructional hours since launching during the pandemic in June of 2020. And many of you, well over half, said that it has provided you with a practice change based on these learnings. And we currently have 45 sites, 116 providers, and you can see where we are throughout the state of Washington. We invite you to share locally, grassroots, spread this as a resource for your community. And now I'd like to turn to introduce Dr. Gina Kang, who is going to talk with us about palliative care considerations in diverse populations. Thank you so much, Gina.
Thank you. So I'm gonna share my screen. And that's still visible for everybody? Okay. Well, Good afternoon, everyone. Thanks for having me here today, and thanks for joining me on this afternoon. So, as Nancy mentioned, my name is Gina Kang. I'm a geriatrician and palliative care provider here at University of Washington. I practice in a variety of different settings, and one of them is at the Memory and Brain Wellness Center as the embedded palliative care provider. So today I'm going to be talking about palliative care in diverse populations. I just want to start off that this is a very broad topic, and my intent today is to provide an introduction and specifically talk more about diverse older adult populations with dementia. So here are just some of the objectives I will cover today. And then to start off, talking about dementia in the United States. So there are more than 6.5 million older adults, which are defined as those over the age of 65 years of age living with dementia in the US. This is projected to grow to 12.7 million by 2050. And then as age is the leading risk factor for Alzheimer's disease, it's not unexpected that with increasing life expectancy, the rate of Alzheimer's and related dementias will also increase. And then of the older adult population, foreign-born older adult population makes up approximately 14% of the total older adult population in the United States. And this population is expected to increase to about 22 million by 2060. And also expected to surpass white non-Hispanic older adult populations. So foreign-born status has been associated with higher prevalence of dementia, higher prevalence of undiagnosed dementia, and more advanced disease at time of diagnosis. So the next few slides, I'll kind of go over more in a graph form or chart version of what I just mentioned. So this chart just shows that older adult populations are more racially and ethnically diverse and will continue to become more diverse in the coming years. This graph highlights the population of older adults in the United States. So we're here in about 2020-ish area, and highlights the 14% of the share of foreign-born population of older adult population in the United States. And then I also wanted to highlight that those who are from racial ethnic groups make up the large majority of the population who are considered limited English proficient. So some contributing factors and outcomes to talk about in older adults with limited English proficiency. So language barrier has been shown to be the largest contributor to higher prevalence of dementia and rate of undiagnosed dementia. Other contributing factors include socioeconomic, health literacy, cultural and psychosocial factors. Specifically to cognitive health, they often lack knowledge about dementia compared to their US-born counterparts and have very limited or lack of linguistically and culturally tailored information and resources that are available to the individual and their caregivers. So those with limited English proficiency have also historically been excluded from research and access to other available resources that might be helpful. It's also been well documented just in general that older adults with limited English proficiency had higher delays in care, lower quality of care, poor patient-provider interactions, and about a quarter of those with LEP reported not seeking healthcare due to fear of not understanding, which is, a big problem. They've also been shown to have higher readmissions and lower receipt of goal concordant care, including less formal documentation of their goals. And as you can see They often receive aggressive care at end of life, more oftentimes die in a hospital, have poor symptom management, receive goal discordant care, and are less likely to know about and also utilize supportive services like palliative care and hospice. So I will switch gears a bit here. I know that Dr. Pattison had gone through this extensively in her talk, but just as a refresher, I'll go through this really briefly. So I like to start off with dictionary definition of the root word palliate. So this is to make a disease or symptoms less severe or unpleasant without removing the cause. And the World Health Organization had a good definition where it describes palliative care as an approach focusing on the quality of life of patients and that of their families who are facing challenges associated with life-threatening illness, whether physical, psychological, social, or spiritual. And palliative care is specialized care for people with serious illness, focusing on how serious illness impacts these 4 domains, which include physical, emotional, psychosocial, and spiritual aspects of an individual's life. And then this illustrates the old and new models of palliative care. I will say, I think, still a lot of people think when they hear palliative care, it's more of the older model where we might get involved more towards the end of life, or as here it mentions, brink of death care. But we know that palliative care is supportive care that is ideally started at time of diagnosis and can get involved at any stage of illness, regardless of whether the individual is pursuing disease-directed or curative therapies. And in terms of who can benefit from palliative care, this is for anyone living with a serious illness, regardless of age, prognosis, disease stage, or treatment choice. It's ideally provided early and throughout the illness in conjunction with curative or life-prolonging treatments. And in the context of dementia, we know that the progression is different. It does not usually follow a normal disease trajectory. It's often slow, steadily progressive. Some of the unique challenges at more advanced stages in illness include communication challenges and decision-making capacity. There's increasing support that's needed for the caregivers. It's oftentimes difficult to define when it may be terminal. And then also balancing the decision of, medical interventions or therapies. So these are some of the areas that palliative care can help within the course of the illness, and especially in thinking through next steps. So with our patients, it's important to start conversations early and keep them open, especially, as the individual is still able to make their own decisions. And some of the important questions to think about is, what matters most to you? Who matters most to you? What is an acceptable quality of life? And also important to establish with palliative care earlier on and follow through the disease trajectory. And then in terms of palliative care versus hospice, I thought Dr. Sagar did a great job in describing it. So it's important to understand that while all hospice is palliative care, not all palliative care is hospice. And in terms of palliative care, we are not here to help patients give up, but rather to affirm their life during serious illness. And hospice is not a place, but a philosophy of care. And it's for those who we would not be surprised if they were to pass from their illness, if it followed its natural course in less than 6 months, and it utilizes a comprehensive interdisciplinary team approach. And this just is a general depiction where you can see that palliative care and hospice share the philosophy of care, but there's, maybe some differences. So palliative care you can receive at any stage of illness, can co-occur with curative treatment, typically occurs in a medical setting, either inpatient or outpatient. For hospice, prognosis of less than 6 months. Usually they're not actively seeking or receiving curative treatment at this point, and typically occurs in what we call a home setting. So it's wherever the patient would call home. And as part of the course of any serious illness, a lot of what we can help with is future planning, especially when the individual has decisional capacity. And so I'm just going to run through the next slides of future planning. So part of that comes with advanced care planning, and this is a process that includes discussions about care preferences and what matters most. It has been shown to improve receipt of goal concordant care. However, this should continue to be an open conversation as goals can change through the trajectory of illness. However, there are some challenges. And so going back to our older adult population, so as we saw, the population is older and more diverse than ever. Foreign-born older adults are different and have unique needs, which we'll kind of go into in the next slides. Navigating end-of-life care is challenging, and as mentioned before, older immigrants are more likely to have lower advanced care planning engagement and completion of advanced care documents, and are more likely to receive goal discordant care. And so there was a study that looked at provider experiences, which I think outlines it very well in terms of some of the barriers and challenges. So this study looked at physicians who reported barriers to conducting effective end-of-life conversations in diverse patient populations. So about 86% of providers reported that conducting end-of-life discussions was challenging in all patients, especially when their patient was from a different ethnicity from their own. And we can see here that most commonly identified barriers included language and medical interpretation issues, religious and spiritual beliefs about death and dying, not knowing about cultural beliefs, values, and practices, cultural differences in health, truth handling and decision-making, limited health literacy, and mistrust of doctors and the healthcare system. And then I just wanted to point this chart out. This also leads us to a point that cross-cultural barriers can really affect the quality of care we would like to provide for our patients. This chart is from a study that explored cultural sensitivity and advanced care planning. I just want to mention it's a general cultural overview looking at differences in values and beliefs surrounding belief in advanced directives, views on autonomy, informed decision-making, truth-telling, and dying process. And within each culture, there are variations. So just kind of, putting that out there, just viewing this as a general overview and hopefully providing some informational context. So first off, I just wanted to point out that the concept of advanced care planning and advanced directives is a Western concept. So in general, westernized views, as we can see at the very bottom, the European American cultural group here, value patient autonomy, informed decision making, truth telling, and discussions related to the dying process. And so the main takeaway is that it's just important to be culturally aware and not elicit our own biases into these conversations. values and beliefs are very important when it comes to these difficult decisions usually, and important conversations. And so from our end, when we're starting to think about having these conversations, these are just some areas that would be important to consider. So really making sure to think about patient and family perspectives. So when it comes to dementia, we want to make sure that we know what the patient and family perspective on dementia means. So many cultures associate this as a normal aging process. There's usually a high stigma attached to having dementia. Some cultures think that this is a psychiatric illness, or that, you know, the person is crazy. In one culture that I was reading about, dementia was often perceived as connected to witchcraft rather than to a disease. And so there was a lot of bullying, shaming, even, you know, physical threats for individuals who have dementia. So just kind of making sure that we know where their perspectives lie. Another consideration is also the terminology and definition of palliative care and hospice. This is usually not a term that's directly translatable or utilized or even known about in different cultures. And so even for, you know, interpreters, it might be hard to navigate through what is this, you know, what is this service and what is this specialty. And also words like support is not typical terms that are used, which I've experienced personally with my own parents, where they were just kind of like, I don't know what you mean by support. Do you mean financially? Because it's not a word that's commonly used in that way. So just to be cognizant that it, you know, it may mean different things, or it may not even be a word that's available. So that kind of goes into the next communication. So, you know, need for interpreter services, making sure to meet with them beforehand to identify like a standard definition of things, and also making sure to see what's acceptable when discussing serious conversations surrounding illness and dying. So, so with death and dying, this is, you know, some cultures may be very open with talking about this. Others, it's a taboo topic, especially when it pertains to elders. And so in front of elders, it may be disrespectful to talk about death and dying. It may bring death quicker, and it may bring bad luck, or, you know, cause the individual to lose hope. And so just wanting to be mindful of, you know, of that perspective before going into a conversation. Other things include, you know, what does suffering mean for people? And our definition of suffering is likely different than somebody else's definition. And who is included as part of the family and decision-making process. So, you know, some cultures may identify it as a shared family decision making process. And in different cultures, again, with elders, they may defer anyways to the adult children to make the decisions. Also being mindful that Western healthcare practices and use of alternative traditional practices tie in closely with having these conversations, and then the role of spiritual and religious beliefs and practices. So I just wanted to end here with this wellness map. from the Alaska Native Tribal Health Consortium Palliative Care Resources. I really liked this. I thought it was a really creative tool that has been designed to guide advanced care planning conversations using the traditional values of Alaska Natives of storytelling and vivid imagery. And I really thought this nurse practitioner's quote was powerful as well. So by giving space and listening to the life experience of an individual, culture is no longer a barrier. So thank you for your attention. And again, this is a very broad topic of itself, and each of these could be a separate conversation and presentation of itself, but hopefully this helped kind of inform briefly of some key things to consider in our practices.
Thank you, Gina, for that wonderful talk. And I'm curious from our community, are there any questions for Gina? Carrie put in the chat how awesome it is to have, to quote, unique and special to have embedded palliative care provider and memory care clinic. It really is fantastic. Mimi.
Thank you. Yes, Dr. King, thank you very much. A lot to think about there. I have a question. A lot of our clinicians, we see a diverse population here in Pierce County in particular. And, we have a variety of interpreter services available to us. When the family refuses to use an interpreter and say that they will do the interpreting, do you have a particular approach to that? We've all been burned by that in the past, and I don't know, it's just come up a few times lately. And I'm just wondering how you approach that.
Yeah, thanks for that question. And I know that comes up, I wouldn't say too often, but it does come up. So how I usually approach it is, just letting them know that the person would be there as a resource, especially with a lot of the medical information that might be, heavy, and also allowing the person who, they might designate in the family as the interpreter or the person they prefer, to let them be the family member and not have to do the extra work of, having to be the family and also interpreter and trying to get in all that information. And so that's usually gone pretty well. And also just letting the interpreter know that we would kind of refer to them during those times when it would be helpful to interpret. And it's actually gone pretty well where, they'll kind of jump in, and then the family also feels like they're involved as well, to the extent. So I think it just depends on the family. And then also if you even share that and they're like, no, I don't want that, then, just respecting that that's not what they want. So.
Great. Sundance, do you want to unmute yourself, or would you like me to read it?
I was just commenting that I've got a couple of patients that it's not dementia specific on that, but just with that rub of the interpreter is that I don't often understand what they're telling me. My mother-in-law fits in this category, and they get very offended and have so far not allowed me to use even our remote interpreter because we have one of those little kiosks because they don't need it. But I sometimes disagree, and it's difficult to get around that issue and not hurt their feelings or be offensive.
Yes, I hear you on that one too.
Hey, Dr. Kang, I just wanted to say thank you so much for that presentation as well as the chart with the different demographics and their preferences. Because for me, that would be really helpful to have when I do prep visits. So that way I can frame my thinking in alignment to particular cultures and then go in with more knowledge to be sensitive towards, as well as, making sure that I'm not making assumptions. So I'm asking those questions to be able to identify what their preferences are. Because I feel like in Western culture, because I can relate, it's easy for me to have a broader understanding. And that map at the end was just so beautiful. Like, I really wish that I could almost provide like a flow chart for patients with the palliative care journey and allow them to fill in what their journey might look like for them and what would be most important to them. So I have never seen anything like that when we talk about healthcare, but my little pediatric heart that loves the idea of guided imagery just was so happy to see that, and that somebody was not only being culturally sensitive, but also being really effective in their ability to communicate with a culture, because they were using their strong points. My question for you is, how do you reach a broader cultural audience? I know we talk a lot about communities, and it's very easy to provide resources for those who know and ask. But in your experience, how have you exposed different cultures to palliative care in order to gain their trust and their buy-in?
Yeah, that's a great question. I think that's still a work in progress. Obviously, it's still a concept that's new, even, to the medical providers, I would say, let alone our patients. And so I know that some of the colleagues that I work with are trying to reach those populations. And a lot of it, I think, has to do with being out in the community too, which I know is hard to do. But I think at least at Harborview, we have the fortune of working with the cultural case mediators who are, very well versed in palliative care and end of life topics. And so again, I think we're spoiled, but working with them, been able to reach more of the, different cultural communities, that this is not something scary. This is, just, this is more of a support and resource. And what does that look like, for each of you? So,
Then Isabella, do you want to unmute and share your comment, or would you like me to read it? So I'll just go ahead and
I'm sorry, I had a hard time finding the mute button, the unmute button. My suggestion is, English is not my first language, and I find that I am seeing people, I'm talking to someone, and I can see in their faces that they don't understand what I'm saying. So I hear you. And I would suggest maybe you emphasize that you need the interpreter for yourself. My English is fine. Your English is fine. I am the one needing the help, not you need help. That might be taken in better than, putting the problem in the person. Not it's you're the one who can't understand me. That might be an idea. Thank you.
Thank you. Anybody else with questions? Or anything, any encounters that people would like to share?
Hi, this is Karen, the caregiver representative in the Echo Dementia, and I had a question about availability and accessibility of palliative care providers. I am extremely lucky that I live in urban King County and am can be linked in with palliative care providers. But before we started today, I was Googling around because my sister-in-law is taking care of my mother-in-law with severe dementia in a private home. And you know, they're in Longview, Kelso, which really isn't that rural, but the Peace Health palliative care provider is all the way in Vancouver, which it might as well be in Beijing for as difficult as it would be to sort of travel to that location for my sister-in-law and my mother-in-law. So I guess I'm just thinking about the landscape of Washington State and where palliative care providers are located, and is there increasing thought and movement about doing, you know, a day a week in, say, more, you know, rural towns or something, to do in-person visits. I know we can do Zoom a lot, and if someone with dementia has a caregiver who's savvy on, lots of times the caregivers aren't savvy on digital telehealth technologies either. But just, you know, what the movement might be currently in reaching out to people who are isolated and have poor access in our state.
Yeah, that's always on our minds of how to reach people. And outside of telemedicine and reaching those who are more in isolated areas, I don't know of what's out there unless somebody here kind of knows more about that as well. I know with us, telemedicine has been helpful to, you know, have a far reach across Washington State. Not so much in person, I would say. For our team, we do, so the outpatient palliative care at Harborview, the providers do some house calls, but it's more geared towards people who are homebound or approaching end of life. And so that's also limited to kind of the geographic, you know, close region to the hospital. But it's always something on our minds that we would love to have a further reach.
Brock?
Yeah, I would just sort of add that, I mean, the advent of telemedicine because of the pandemic has been absolutely game changing in terms of continuing to be able to follow people at home. I mean, I think, you know, my experience as a primary care doctor is that I would so often really like lose touch with people who are nearing end of life because they were too ill to come into the clinic. And now I can have telemedicine visits with them and really continue that care like far longer into their serious illness than I used to be able to. And so I think telemedicine is a huge boon for palliative care. You know, whether somebody lives near the clinic or far away from the clinic, that you're still able to kind of provide that that care. The really hard question that I struggle with all the time. And first, let me just say, you know, Dr. Kang, it is so great to have you at the Memory Brain Wellness Center, and it's so great to have you with us today. This is like, you're filling such an incredibly, you know, huge need, and it sounds like you're so sort of thoughtful and careful about how you're trying to meeting that need. And you know, the questions that come up for me as you were giving your presentation is like the, you know, like when you mentioned how there can almost be this sort of sense of bullying that can occur with the different cultural sort of milieu that some families are in, and which also like then kind of like connects somewhat to the like refusing the interpreter, just like that super like tricky nugget of, you know, like at what point do you stop just sort of completely deferring to the family and saying, oh, this is your cultural situation, and I'm going to kind of completely suspend my sort of, you know, what I think of ordinarily as my sort of duty to the patient and their autonomy. But then there's a fuzzy line that can then be crossed maybe, where maybe that's not what the patient wants. Like maybe the family is more focused on sort of like the kind of control and that, and it's sort of like almost kind of like, inappropriately sort of blocking the patient's voice from being heard. So, I mean, there's obviously not an answer to this, but I'm just sort of like raising it as like a tricky issue that comes up in this area.
Definitely. Thank you for bringing that up. And yes, I've seen that in different ways. So again, that's individual as well. I know that a few that come to mind during an inpatient setting was, they kept deferring. The daughters kept saying, like, don't talk to my mom. This is gonna, bring her a lot of stress. And she had, I think, metastatic cancer that she didn't even know about. And so it was just kind of one of those things where I think the team was more distressed about it, but going back to the patient, really asking her, how would you like to receive your information? And she mentioned that she doesn't want to receive the information, and please just relay it to my daughters and they'll make the right decisions for me. And so I think that, just kind of asking the simple question of like, how do you like to receive your information can really help. So
Yeah, and it's interesting to think about the difference between the inpatient setting and the outpatient setting, because like in inpatient setting, like the patient is sort of this captive audience. And so it's so easy to have a conversation with them when they're there by themselves. But then in the outpatient setting, it's really awkward to say, oh, can I speak to your mom or your dad alone for a minute? Which is just like a very, very hard and awkward thing in the outpatient setting.
yeah, or the opposite, where the family member is like, can we talk to you and not include, my loved one because X, Y, and Z. So
Yeah, that's what I was actually going to mention, especially with dementia and for people who have some of the more paranoid delusions and so forth. What are the ethics or the legalities of talking to the primary care partner without the person in the room? Because if they have dementia and they're paranoid and they think their care partner is occasionally trying to kill them or, put them in prison or something. So they're going to say, no, you can't talk to my wife or my husband or daughter or something. And it's like, okay, what's the actual validity of that statement? Or my husband, who just has a lot of aphasia and different language problems, he uses the wrong word. It's like, oh, do you want some hot soup? He'll say no, but he means yes. And so the word coming out of his could be opposite of what his intent is. So that just seems really tricky. So are there litigants talking to the care partner without the actual patient in the room or being part of the conversation?
I'm sorry, I didn't catch the last part. I think it cut out.
Oh, just wondering what the laws or the ethics are of talking to care partners when the actual patient who has dementia is not in the room or on the Zoom at the moment, so you can have a frank conversation about what's going on and what the care partner thinks might be best for them, assuming the care partner has all good intentions and is not an abusive or neglectful care partner.
Yeah. So, with anyone in older adults, we like to always have a loved one there, just to provide that additional background. And so I don't know the exact ethical and legal aspects of it, but how I kind of approach it is, I'm getting information from, the background information. And so if there's a way that I can get that from the care partner, That's part of my assessment as well. And so, yeah, as you're talking about that, I was thinking of one of my patients who gets pretty angry when anything's talked about with him. And so it was more of like a discussion of, let us have a separate conversation just so that I can support you as the care partner who's going through this. And so with that, also, can you just kind of tell me what's going on in the home? And because we weren't getting anywhere. So that's been one strategy that I use. I don't know if there's others that other people have used, but
before a palliative care visit, whether in person or on telemedicine, is there a little worksheet? I know every time my husband and I go into the memory and brain wellness clinic, there's a worksheet for him on a clipboard, which he can't fill out anymore. So I quickly do that one. And then there's one for the caregiver. And that has, of course, different questions. But I always appreciate that box. It says, what do you want to make sure you cover in the visit today? And so I can put something secret, like sometimes he's aware that we're talking about him and he'll get kind of like, don't say that, in front of this other person or something. It's like, no, I need to know what's actually happening with you. But whatever is, embarrassment or outing him or exposing him, or he thinks I'm making fun of him or saying something unflattering. So having that sort of written ability, like passing notes in class, like, let's not let the patient see what we're talking about, but I want you to know what the big issue is. And then it'd be great for the palliative care person to be able to sort of message back, like, when this person talks, is it actually a valid thing coming out of their mouth, or is it a language problem or just confusion?
Yeah. And at Memory Brain Wellness Center, we get those same sheets. And so that's helpful for us to know, are there other things that you would, you as the loved one would like to talk about? And so those are really helpful for us as well.
And that's something I think any provider's office could, if they don't do it already, could initiate when there is somebody coming in with dementia, with their caregiver, just having, here's your clipboard and here's your clipboard. And then they're not going to get to see what the caregiver writes.
Yeah, that can also sometimes be done, and this is likely some of yours experience, through my chart with an update before the visit or a follow-up, and to convey that information in a way that's not disruptive or upsetting. Brock?
Yeah, I mean, I would just add, like, this is just another one of those, there's no easy answers, like when you say, like, well, what are the legal and ethical implications of this? It's like, well, it's like, it's a super gray fuzzy, there are, I don't think anybody could really say, here are the legal rules or here are the ethical rules, because it's just so hard to try to strike the right balance between making sure that the patient is included in the conversation as much as possible, but also, like you just point out so beautifully, Karen, about how there is definitely the risk of causing distress in the patient, where they are aware that there is some really deep, important, serious conversation that's happening in their presence about them that they can't really quite follow. And that is, and I mean, so I often will advocate for trying to do that, to try to have the serious illness conversation, goals of care with the patient there. But if I'm starting to sense that it's causing distress for the patient and that they're not really understanding what we're talking about, but they are understanding that it's sort of deep and important, then I will often try to then kind of shift the conversation to something else, and then really try to have a phone call conversation with the family member with the patient not there, which doesn't feel great. I mean, like in an ideal world, it would be wonderful if the patient could always be part of the conversation. But there definitely, I think, does reach a point where, as you're like trying to navigate that balance, the risk of causing alarm and distress in the patient is pretty high.
Yeah, and if I could just follow up on what you're saying, Barack, as well. I mean, I think that as we all are caring for individuals living with dementia, and within the framework and milieu and context of a care partner and environment, addressing the needs and concerns fully of that care partner is a key component of that care, as well as we all have felt on so many occasions. And ideally, it would be great if we could do that each time in the office, in the company of the individual who's living with dementia, and at the same time, as we've all experienced, it's not always possible. And yet it's such a key element of that comprehensive team care. Trang.
Thank you, Dr. Kang, for the wonderful presentation. It's great to think about how to take care of dementia patients in the diverse patient population. Sometimes I feel that a patient, they might not want to know the whole community know about the disease. A certain ethnic community is small. The reason sometimes I feel like they don't want interpreters especially, or even caregiver, because of that small community. I had a patient who came to the clinic and actually realized that I am the daughter of the parents, so that actually my parents know them. They freaked out. And they were so concerned. They asked me to promise them not to tell the family. And I assured her, I said, this is actually my duty, not only my duty, but also the law. I can't say anything. But even that, she never came back. Because she was so concerned that the whole community would know about the disease, especially when it comes to psych illnesses. So I'm very glad that now we have the interpreter, that we can use the phone. No one knows. No one on the other line would know who the patient is. She don't know the face. So I'm glad to see that. But before, when everything was in person, the interpreter in person, the patients resisted. I think also there's that reason as well.
Yes, thank you for bringing that up. Yeah, I resonate with that personally too, Trang, because our community is small, and so just my parents are also hesitant sometimes. So yeah, there's different modalities of interpreters for different circumstances that are helpful. I've had patients also say they don't want interpreters because the community is small and everyone will know their business. And so that's, so yeah, thank you for bringing that up.
This is Marielle again. In the last conversation that we were talking about, being sensitive towards patients, especially when they are in the middle of their disease process, right, where they have enough understanding and awareness. And my thought was, how do we make this point of contact at the time of diagnosis, right? Not waiting until there are symptoms to start unpacking, but be able to start drawing the roadmap early. So that way we're not having to do more harm to these patients, right? When they're in the middle of their process and the family is feeling a lot of tension because they're dealing with more crises and stuff. So Dr. Kang, how have you guys been able to implement palliative care early on, at the time of diagnosis, as opposed to when there's more complications coming down the line and the doctors feel more pressure to manage those symptoms?
Yeah, I think for us, just kind of mentioning that I'm part of a team, I think has been helpful. And it's not that the first visits are long or anything, but just introducing, what it is that I can offer has usually been helpful when it's people who are earlier on in the course of illness. And because, most I think would be a little bit scared or hesitant if they kind of hear like, oh, what do you mean we're going to be talking about end of life? And so just kind of reiterating, I'm not just end of life, but I'm here to support you. And early on, you may not need me, but at least there's a face to the specialty name, and I'm part of your care team. And so utilize me as a resource. And, that's kind of worked better than being like, okay, so we're going to talk about planning and, when things get worse down the line, or, that type of thing. So I think just kind of introducing this is a resource. It's, part of kind of the process of having this type of illness, and just making it as normalized as possible I think has been the most helpful.
Yeah, I totally agree. I feel like I start almost every visit with, oh, you're a step before hospice. And I'm like, no, I'm not a step before hospice. And I'm really sorry that I'm getting to you guys in a very critical time of your disease process. So I didn't know if there were things that you guys were doing to trigger palliative referrals sooner, like if there was like a PPS or a FAST or some type of screening that you provided to help those referrals come in sooner.
Yeah, I don't think we have anything standardized yet, but I know that with Karen, we've been talking about what would be kind of an ideal process to get that earlier, rather than like you're mentioning in a crisis or more further on down the road.
Great. When you guys come up with that, please share.
Yeah.
Also, I'll just add in, I went and grabbed my Dementia Roadmap brochure, which I got early on at Memory and Brain Wellness, and I devoured it. I know not all cultures read, so I guess it'd be good to know that this is translated into a lot of languages for people who do use materials, but maybe it could be turned into a little series of short videos or something. Because even when people don't read, almost everybody has a smartphone and is doing videos. But maybe in each section, like early dementia, what should you do? Middle dementia, blah, blah, blah. There's the action steps. And maybe in the next iteration of this, get a referral or consult a palliative care provider, and maybe put that in each early, middle, and then late dementia, as opposed to the usual stuff that's in here that's, get a durable power of attorney, complete an estate plan, have a family meeting, blah, blah, blah. Great stuff, but maybe adding palliative care, because it also didn't occur to me until just recently when I found out about you, Dr. Kang, because some of my friends in my dementia support groups are saying they've had visits with you. And so I just had a telemedicine visit with Dr. Personair, my husband and I, last week. And I was like, is this appropriate for us? Can we do this? And I'm a healthcare provider. And I still was like, is it too early?
It's never too early.
Right. Which now I know, and now I'm gonna sing that out to all the support groups that I'm in.
Thank you for those suggestions too about, reiterations or other resources that we can think about. I think those are great suggestions that we'll put in my list.
Thank you, Liliana.
Hi, everyone. So I have a question that's kind of in addition to Dr. Pattison and Dr. Lee's questions on interpreters. So how do you navigate ethically a family who is denying interpreter services because of that small community concern for privacy? Very legitimate perspective. How do you, if the patient is not the person who is able to do the translating within the family, how have you navigated it to assess someone's decisional capacity and have a goals of care conversation when you wouldn't be able to verify if the information is coming from the patient or if it's coming from the family member answering the questions and providing the translations?
That's a tough question. I'll just put that out there. So, kind of going back to if those strategies that we talked about absolutely do not work. Yeah, that's been a tough one. Typically you just have to kind of get by in a sense, especially if they're refusing multiple times and decline it every single time. And just have to well document it. I've had one patient who refused every single time, and there was kind of question also, but out of respect for the patient, not having to kind of force that on them, even though not knowing what their true decisional capacity might be, which is a challenge obviously, but just he even would like kick out the interpreters, so and cause more distress on him to have that person there. And so yeah, just having to document that it may not, these are our concerns, but the patient has declined multiple times and has in fact kicked out the interpreter too. So
Very
Thank you.
difficult. Thank you. Karen, Clay. Karen, you had your two.
Yeah. Yeah, I was thinking back to Mariel's question about introducing palliative care, and I also work at the Memory Brain Wellness Center, and this is something that Jean and I have talked about and kind of struggle with too. And I think, for us, one of the things is sort of focusing on our providers, on really like thinking about ways that they can frame things about how kind Gina is, how she is just really great person to talk about the things that are important. So really sort of spending that energy on providers about sort of like this helpful, supportive person. We've also talked about, and we haven't gotten to this yet, but sort of putting up like a bullet, like a flyer, kind of like, hi, if you're interested in talking about values or something like this, palliative care service, or this service is available to you, ask your provider about that. So that's still something in progress, but again, something to sort of help us normalize, like, hey, it's about values. And then ideally having a photo to be like, this is a warm person, a kind person that is here to help you. And then also sort of thinking for us about, for me as a social worker, when people are talking about the fact that they have multiple kids, they're not married, that sort of keys to me that like having a power of attorney or health surrogate would be helpful for them. And that's another potential inroads for introducing palliative care service for services in terms of helping them navigate that particular piece, which might be a little bit less threatening.
Yeah. And Trang?
Yeah, I want to go back to Liliana's question about the patient that refused interpreter. I think if the patient can speak enough English that we can understand, then I think it would be okay. If the patient has, if we have a hard time understanding the patient, then I feel like the interpreter on the phone is very helpful. I did it with my mom, and I thought the interpreter actually did a better job than me interpreting. And my mom was totally comfortable talking about uh, talking to the person on the phone because she doesn't know the other person on. So I think not having somebody face to face, I think it really can take out the barrier. So I'm glad that that option now is available. It wasn't, it used to be like.
Yeah, in this particular case that happened last week, so it's very fresh on my mind. The patient's wife was the one who was verbalizing refusal of the interpreter, not the patient. And they were not open to a phone interpreter, but I love that as an idea to be able to say, this is an avenue by which you can maintain some degree of privacy because they won't be seeing you. If that's a concern, it removes one barrier. So certainly I'm going to be taking notes on all of the suggestions you've all said and kind of have that in my back pocket for the next time this will happen, because I'm sure it will not be the last.
Yeah, and I agree with Dr. Kang too. You know, if they keep refusing, then thank you for the question.
Thank you. Brock?
Yeah, I mean, I've just this is such a great conversation. Like the term palliative care has been like so problematic for so long, right? I mean, it is so deeply embedded in our culture as something that means end of life, and or giving up, or switching to comfort focused care only. And so it occurs to me that taking some lessons learned from the oncology world, where they have really moved away, like, so if there is like a palliative care person embedded in an oncology center, where they're really encouraging earlier referrals to that person, even if there is maybe still sort of active sort of cancer treatment happening, that they've used terms like the symptom management consult, and that it occurs to me that in the dementia world, there may be value to using a term like that, because I mean, like on a national level, like I've been at meetings recently where I've really been advocating for, the words palliative care to be introduced earlier in sort of dementia outreach, education, public health initiatives. And there's a lot of pushback because, as soon as you start talking about palliative care with dementia, everybody is like, oh, that means, you're sort of like giving up, and, you're switching to comfort focused care only. And as opposed to the wider concept of palliative care, that it's like symptom management and it's long-term planning. And so I mean, it's really, really hard. And it really is so kind of baked into the baggage that the term palliative care carries in our language. And so I think the symptom management consult might have some legs in the dementia world.
I just want to jump in and say my old hospital was able to successfully rebrand palliative care as quality of life team. And so it was really interesting to see how this doctor was able to reframe this entire program. And it was pediatrics, so it was fun, and there was koala, and it was very something that was personable. But I didn't even know until I started working in palliative care that that's what it was. That's how well embedded it was into the flow of care that was provided. So the day that you hit the door, you kind of were introduced to that. So yeah, just it's ingrained. It's a cultural thing. It's a society thing. And so I do feel responsible to help with that reframing and doing whatever we can. So I love the idea of the posters and things like that to make it just normal, right? To make it a normal part of holistic care.
And Karen, we have a couple minutes.
Yeah, I just wanted to speak from the caregiver community. Most of a person, except when somebody has a really long-term engaged family practice doc or general practitioner who knows them well and sees them as a whole person and a whole family. Almost to a person, our experience is as soon as you get the diagnosis of MCI or Alzheimer's or Lewy body or whatever it is, what we're told is get your affairs in order and go live your life as long as you can. And then sort of like nothing except medication, maybe some medication management. But we all feel like we get dropped off a cliff with this, get your affairs in order. And then the neurologist or whoever's on to the next, fresh patient coming in. So however you're going to call it, but maybe palliative care is a term that's too misunderstood. And so coming up with another term and having those links to get somebody in for symptom management or even planning kind of has a word, planning for your death kind of thing. But I'll say I think the caregiver community, and I can't speak for someone with dementia, but I think that would be warmly welcomed to know that there's going to be some continuing attention to living your full life, even with this progressive degenerative disorder. And people would feel less abandoned and less sort of the blind leading the blind, which is like a lot of our giving groups that I'm in. I mean, people are great, have great suggestions, but it would be great if it came from the medical team. But I think the medical culture also needs to change a little bit. And not just say, get your affairs in order. Let me know when you need hospice.
Thank you. Thank you for sharing your perspective. So important. And we have a lot more to do in this area, clearly, this complex area. Thank you, Dr. Kang, for the outstanding talk and really rich conversation. And lastly, we will see everyone who can make it on December 9th for Dr. Angela Hansen's talk on diet, a solution-focused exploration about how to help folks to, I would say, add in and promote healthier options. Okay, so on the dot. See ya.